eyes and your vision are under attack. Damaging blue light from the sun, your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
Do your patients know what presbyopia is?
There are people who are afraid of the press.
Have you talked to your patients about multifocal contact lenses?
I've heard the bifocal, but not multifocal.
Exactly, not multifocal.
Do you need help with your multifocal strategy? Learn more at the conclusion of this episode. With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you. Good morning, I'm Dr. Kerry Gelb, and welcome to Wellness 1280 on Open Your Eyes Radio. Please listen as I discuss the newest information in the world of health, nutrition, and sports every Saturday morning, 6 a.m. Central Time on AM 1280 The Patriot. Also, please share your thoughts by emailing me at drkerrygelb@gmail.com. That's drkerrygelb@gmail.com. And visit my new website, wellness1280.com. where we have all guest links, Wellness 1280 info, and previous shows. Wellness is taking over the Patriot Airways for the next hour. Sit back and enjoy my interview with Dr. Mike Johnson. Your eyes are under constant attack. Dryness, inflammation, infections, even surgical trauma. But what if nature provided a powerful way to heal and protect them? Enter corneal amniotic membranes, a revolutionary treatment harnessing the regenerative power of human birth tissue to restore and safeguard vision. From severe dry eye and corneal ulcers to post-surgical recovery, this cutting-edge therapy is transforming eye care. But how does it work, and who benefits the most? Joining us today is Dr. Mike Johnson, an Alabama-based optometric physician, consultant and lecturer at Ophthalmologics Biological Tissue, owner and managing director of Excel Eye Care with Excel Health Group, and managing partner and national provider trainer at Nuvisa Ocular Devices. Dr. Johnson will break down the science, the impact, and the future of amniotic membranes in eye care. Could this be the key to unlocking a new era of vision restoration? Stay tuned. This is Open Your Eyes Radio and Podcast with Dr. Kerry Gelb. Mike, welcome to the program.
Thank you. Thank you, sir. Feel honored to be a guest.
I'm so happy to have you. I want to ask you, so what is amniotic membranes?
Sure. So amnion tissue or amniotic membranes, in the sense of where it is coming from and what is it from a basic principle, is the fetus is protected by the placenta, and the outer layer that's towards the outer portion toward the mother is the chorion. The innermost lining that is closer to the amniotic fluid is the amnion. And we know from scientific studies that the amnion possesses the antibacterial, the anti-angiogenic, the anti-inflammatory, all of the properties that you want to promote a healthy tissue, healthy promotion of wound repair, if you will. And the beauty from an eye care ocular perspective is that it's 5 layers thick, which is bioidentical, biosimilar, if you will, to the 5 layers of the cornea. So the beauty is that the basement membrane structure all the way to the epithelium of this chorion can absorb and readily and almost immediately take on the properties of the compromised or damaged, infected, scarred corneal tissue, but you can also use it for lid margin issues. You can use it for the conjunctival issues. There are some procedures where you have repair to the conjunctiva that we'll probably talk about in a little bit. There's some other new technology, but yes, what is amnion or amniotic membranes? The process where a lot of companies are lowering the tissue in either a lower temperature state to dehydrate it. And in our case, with the ones that I use, we lower it with an air dried process. So there's no chemicals, there's no preservatives. It is just its preserved state, and it's dehydrated. So it can stay in its packaged form for 5 years. You don't have to use it. You don't have to store it. Some of the original products that were on the market 15 years ago, they had to be stored in a very special freezer at a certain temperature. But so that is what amniotic membranes are. It's a dehydrated tissue that has all the properties to immediately give a response and a healing time.
So the amniotic membrane, let's just go back for a minute with the
Sure.
baby. It protects the baby, gives the baby nutrition. But early in the 20th century, they found that the amniotic tissue would be very good for wound healing and reconstructive purposes. And what are some of the factors within the membrane? Now, before we even get into the eye part, that the amnion has, is it growth factors, hyaluronic acid, cytokines, stem cells? How do these help the body with burn victims, foot ulcers? It's very big in podiatry now with foot ulcers.
Huge.
So talk about some of the non-eye indications of where somebody would use this type of regenerative tissue.
Right. Well, you hit the nail on the head. In the nursing home section or in the wound repair section, that's a big market for it, where your podiatry, your ulcers, your bed-bound sores. There are a lot of dental procedures where you have gum procedures or gum disease where you can apply the amnion. Facial issues, as far as depending on how you want the amnion delivered, it can be in a dehydrated tissue substance, or it could be in a serum where you can apply it to eczema, rosacea issues. You can use it with scarring as far as post-procedural for the aesthetics world, where you can apply it, with your red light therapies, and you want to increase the healing time, as far as your plasma fibroblast procedures, or these individuals that are using facial aesthetics and they want to see a rejuvenated look. You can also see it in a serum formation with hair restoration and helping with the fight with the loss of hair follicles, and help stimulate that.
Wait a minute. Hair restoration? I want to hear more about that.
I'm not really sure if you're in the scenario. I think you might have passed the window for that one, sir. But no. So what you're looking at, individuals that might be looking at spending thousands of dollars on hair transplant, and you want to be able to use the transplant and then have the follicle in place and help promote, or think of it like in its simplistic terms. If you're planting a crop and you want to have a nice bed, if you will, to put that follicle in place, well, the soil needs to be enriched with fertilizer type substances. And so the amnion is literally like a membrane cellophane tissue that you can apply all of the fertilizer growth factors, the anti-angiogenic / neovascular properties. There are some other properties that are on the horizon where you might see in the eye care world that there are studies being done for using insulin directly on the eye to help reduce scars, infections. That's if you're in the LinkedIn world. We already know that because the insulin-like growth factor is already present in the amniotic membrane. As far as our testing, we already have that as far as one of our pamphlets, as far as the properties. The receptors that help block any type of scar formation, promoting the reduction of the fibrosis or the anti-fibrotic, so that you can reduce scar formation. That comes into play for you individuals that have had scars, the wound repairs. And then from an eye standpoint, circling back to that, you may have patients or people that are in the audience that have had these shingles with eye-related infections, and the second and third recurring, where you can reduce the infection and then apply the membrane to help reduce the scar formation, which is where the permanent reduction in vision is. So yes, there's a world of properties for this
To
tissue.
make some comments about it's being used in burn units. It's been used in burn units for a long time. How does it help people with that have burns?
Right. So depending on your layer of your burn, and when you're talking about amnion for the eye, it's a very small. We're talking, 12 millimeters or less. But in the wound area where you're trying to not necessarily have to get a transplant tissue from a piece of the body or another portion, you can add that. What is it going to do? It's going to allow that basement membrane scaffold, especially if the burns are going to a deeper layer, but it's going to allow you to help prevent any kind of infection from setting in and immediately allow that tissue to start healing back to its normal properties and reduce that scar formation or that pulling slash traction of that collagen tissue.
It's interesting because they lack immunologic markers. So there's lack of allergy from this. So I
Correct.
think you get a big allergy because you're using an amniotic membrane from somebody else, but there's lack of allergy. Is it a problem because we're using a tissue from somebody else that they're going to get allergies? So Mike, can you elaborate on that a little bit?
Sure. So the tissue itself, when it's processed, first of all, the tissue that we are getting is 100% from voluntary donated mothers, where we have done their testing, making sure it passes all the FDA requirements, the ISO requirements, and as well as the FDA tissue donation requirements. And it's also from voluntary scheduled cesareans. So the tissue that Ophthalmologics uses for their production of the ophthalmics amnion, we know where it's coming from. There's no cross contamination. The sterility factor is there.
How do we know about like communicable diseases like HIV, syphilis? Do we have to worry about that?
No, you don't. That 100%. So inside each packet, they actually have by requirements the testing, so that we know every tissue has been tested when the mother signed up to be a voluntary donor, and we have specific groups and hospitals that we have assigned as our donation and harvesting hospitals. But once the cesarean has been performed and the tissue has been donated, it goes through a second round of testing to confirm that the original testing. So you go through 2 rounds of testing for communicable disease or any type of outlying factors, whether that individual had some type of bloodborne pathogen or something in their system present. So the risk of having a cross contamination or an exposure, if you will, to that is zero, because the tissue would not be viable in that case.
So
When we're
let's go back to allergies because
Sure, yeah,
it has a lack of immunologic markers, which are these little markers that bring in the immunity to fight a problem or cause an allergy. So it's very interesting how it has a lack of that. Could you
that
explain?
is correct. I would say that in the same sense, if your audience is familiar with stem cells or tissue transplant cells, to where, like you said, there's no biomarkers present to where it would be having that T cell immunologic response. So this tissue is it's got an avascular layer, and it will take on the properties of the tissue that it's absorbed into without having that immunologic slash inflammatory response. That way you don't have to worry about a graft host rejection or anything of that nature. The other thing from an allergy standpoint is there are some companies that use a preservative, some of them an alcohol base, and some of them have a little small sulfur base, to where they're dropping the temperature quickly and freeze drying it, and then they use a chemical. So some of the brands out there that are available, and there's several brands out there, will use a little mini preservative base. So if you have individuals that have a sulfa allergy, they might want to just double check and ask about the product being used in the clinic that they're attending. In the case of Ophthalmologics, we lower the temperature, and it's an air dried production system. There is no preservatives, and there is no risk of any contamination or exposure to sulfa or any alcohol bases. I will say that also that the Ophthalmologics tissue amnion, there's 2 different facilities. One is for the wound tetra division that has to do with the podiatry slash gum disease, and then the other one is strictly ophthalmic. So we know once we get a package for, depending on which product is being ordered by the provider, we know exactly where it is harvested from, where it was donated from, what hospital system, and then also which process it went through from start to finish.
Now, it's interesting because people want to know that this is safe, and a lot of people don't know anything about this, and that this is really, we use this in my clinic. I have placed, hundreds of these membranes and have helped many, many people. And we're going to get into the eye, how it helps the eye in a little bit. But I want to talk a little bit about some of the properties of amniotic membranes and why they're helpful. First, I want to start that they're anti-inflammatory. Explain why that's important.
Sure. So I would say one of the underlying issues with dry eye is there's different types of dry, from an inflammatory dry eye where the surface has, to the general audience, we have these little particles in our tears that cause the tears to either be too acidic in pH or not enough. And if there's a presence of these particles called MMP9 proteins, then the surface itself will lead to the individual having burning sensation, or the breakup in the actual tears holding themselves together because they won't withstand, and the oils that are on that surface will not be of a good quality. And so the anti-inflammatory properties of the membrane help stabilize and cause the MMP9 levels present, and the osmolarity, which is just fancy word for the pH slash acidity of your tears, to be calmer and allow for the every time you blink for the tears to displace across your eye in a uniform layer, not to evaporate as readily, and stabilize that inflamed, irritated surface, to where instead of having to use eye drops every 2, 3, 4 hours, the idea is to absorb that membrane, that amnion, into the surface and allow the healing to be there for comfort, and to have a longer sequence of time to where you may not have to use the drops every 2, 3, 4 hours, but allow you to get breaks and a reprieve from the burning and the sensation. So anti-inflammatory is a huge component, of the amnion.
Yeah, because we want to be careful of chronic inflammation, because if we get chronic inflammation, that's when we get scarring and we get haze where people can't see through the cornea of the front of the eye. It'll delay healing. So that's very important. Let's talk about a second property, delayed scarring or anti-fibrotic. Why is that important?
That's huge. So when you're talking about a cornea being the front of the eye, an individual that has chronic dry eye, to where the tears are not in that area and it's exposing the nerve tissue and not telling the brain to produce tears, or that this area is exposed and being painful, then the area will dry out and scar. Or if an individual has chronic infections like herpes simplex keratitis, or what we have a lot of dystrophies like Meesman's nodular dystrophy, where you have an exposure to the surface and the elements of life, the wind, the air, cause that area to kind of get a smoky white thing. So the cornea is normally crystal clear. And when you have a scar in the eye, the way it responds, whether you had an injury or whether you had some type of infection or chronic inflammatory issue leading to a scar, then you'll get a fibrotic, almost like a white, hazy scar formation, and it can go deeper. So the amnion itself, if you can stabilize the infection from the dendritic ulcer or stabilize the tear inflammatory surface, the amnion itself can help absorb in and resurface that damaged, scarred area with those anti-fibrotic slash healing properties.
So a next property of amniotic membranes and why they work so well is they prevent new blood vessels from coming into the eye. Why is that important?
New blood vessels coming into the eye imply that there's a proliferation of new vessels that are what we call neovascular vessels that are unstable. In the cornea, when they're growing inward, then you have a pathway for the other opportunistic infections. So the blood vessels can be a pathway for the bacteria that can be traveling through that system. It can be a pathway for the new growth of tissue to cause the corneal tissue, or what we call pannus, to set in, to where you have a more opaque surface or scar formation with the proliferation of the new blood vessels. New blood vessels are not a good thing for a pristine, clear cornea. It would be the same effect of you having a crystal clear kitchen window pane and you see little mini cracks coming in from the side. Well, there's breaks in that perfect surface that are allowing other particles, other fluids or other things to leak inwards. So you don't want new vessels because this leads to other future problems.
And it also has antimicrobial properties, which means that's doctor speak, which means there's a less risk of infection or a decreased infection. Can you talk about that for a minute?
Sure. When you're talking about eye-related infections, the number one thing from a clinical perspective is I'm not going to treat an active infectious ulcer directly with an amniotic membrane. That's a little bit off the scale of what our mode of practice is. We want to see an improvement through the standard of care. So we're going to put you on the topical antibiotics to reduce that. But the second we start to see that infection start to recede or start to stop and heal itself, that's when you can go in and add that amnion so that no secondary opportunistic infections come into play. Or let's take back to the whole wound repair where you have an individual that has an open wound on other parts of the body. The risk, especially in hospital settings, and then I do a lot of work in multiple states with my nursing home care. There's always the risk of those nosocomial, secondary infections of the bacteria that lives all around us. So if you can apply a membrane to an eye that has an open sore or what we call an epithelial defect, you're going to allow that tissue to heal and cause that surface to resurface healthier. You're going to prevent the blood vessels from coming in, but then you are preventing any further secondary infection where there's already a break in tissue.
And there's over 700 publications on the benefits of amniotic membranes for people that haven't heard about this. And it really helps with wound healing real quick, much quicker than you would do if you just put a bandaged contact lens in the eye. So we would have, in the old days, we would just, someone have a wound, we put a bandaged contact lens. Now we could use this tissue to help heal wounds, and they do really, really well with that.
Usually it's an immediate response. I would say we want the amnion to be in place. 3 days is optimal for the complete absorption of the amnion, but usually within 24, 48 hours, you're going to see that whatever that defect or that wound on the eye or the other tissue, you're going to see the beneficial results of it.
And when we get back from the break, we're going to talk about dry membranes and wet membranes and what the difference is. This is Dr. Kerry Gettle, Open Your Eyes Radio.
MacuHealth, your science-born and tested solutions for visual performance, macular degeneration, and dry eye syndrome. New products coming soon. Embrace the science.
We're back with Dr. Mike Johnson, consultant and lecturer for ophthalmologics, biological tissue, Inc. He works a lot with amniotic membranes, and he's teaching us about that today. And there's two main kinds. There's a dry kind and the wet kind. So if you could start off with the dry, the pros and the cons of having a dry membrane, what the pros and cons are for the patient, what's the pros and cons for the physician?
Sure. So yeah, I'm a little partially biased, so I'm going to say there's not that many cons on the dehydrated, other than, I would say that the dehydrated tissue came out of play where the pros, it's got a 5-year shelf life. Our product, Ophthalmologic, has a 5-year shelf life. There are some brands that have a 3-year shelf life, depending on how they were producing it, but it lasts longer. You can store it at room temperature. It's a very small, it's the size of literally an envelope that holds it in place. You can get it in different sizes. So usually from a cost standpoint, it's a pro because investment wise for the provider, it's a lot less. It's fractional compared to the wet / there's only one real wet product out there that's made by a company, and then you have to keep it in a freezer, and then you have to lower the temperature down. But from a con standpoint of the dehydrated, I would say that all of your normal eye-related conditions It's clinically indicated. I would say that the only con would be that if you have a severe neurotrophic effect where you're wanting a severe thinking about doing oxervate, and the listeners out there, if you have neurotrophic keratitis, it's a very bad scenario where it's a very sick eye that's losing its nerve sensation, and so that surface is pretty much dying. So I would say the con would be that you would not want to use a dehydrated in a very severe grade 4 neurotrophic case. More than likely you're going to have a corneal specialist involved, and then your next step would be looking at a $1,200-$1,400 eye drop called oxervate that's just pretty rare. So I would say that if in my clinical decision making, I normally almost always do the dehydrated. The pro is that it comes in a smaller size. You can go all the way to a 5 millimeter. In a nursing home setting, you might have your patients that are in a physical position, whether in a wheelchair, or they may have a kyphosis where their neck just doesn't allow them to sit back a little bit. You can go to their bedside and apply it. And if a pediatric population or an older patient, they might be fighting you a little bit. You might have to kind of move them around. So a smaller membrane size tends to be a pro when it comes to that. The other thing is Ophthalmologics is the only company that has an open port membrane where it actually has a hole in the middle. So if you have these individuals that are on the go parents and they have to work, or they're professionals like a fellow eye doctor, and they know they've got a recurrent corneal erosion where they feel the sharp pain, but they still have to work for the rest of the day, and they don't want to have a slight reduction in vision, you can use the Aurora, place the membrane, and go to work about your day. It's a beautiful membrane that you can use in the sports setting. I just had a case the other day. I care for a Division I college team, and so the individual had an abrasion, but they also were about to get into round 1 for the NIT. So we were able to apply a membrane. They were still able to practice, still go travel the team. Never missed any kind of practice or anything like that.
Let me interrupt you here for the Aurora, where they have that aperture. There's like a 5 millimeter aperture, so you could see through it. And you also make an Eclipse, which doesn't have the aperture.
That's
Why
correct.
why would anyone ever use the Eclipse? Why would you use the Eclipse and not just always use the Aurora? Because you could see better with that. Is there any advantage of using the one without the aperture, the Eclipse without the aperture, that you could see better with? Is there any advantage to the Eclipse? Why use?
I would say there was definitely an advantage if you have a corneal finding that is in a specific area, right? So if you've got an 11 millimeter cornea and you see a specific abrasion slash defect, or let's just say you had a dendritic ulcer that was down at 4 o'clock and it was in a very specific quadrant, I would want to apply a membrane, a 5 millimeter or an 8 millimeter, directly on top of that so that it can get secured, adhesion, and absorption maximal into that spot. But now if it's a case where this individual's got dry eye and it's diffuse, it's just all over the eye, and I want them to have a good absorption and a good spread, because the amnion is going to get a lateral spread. So the little open port, 5 millimeter port. Some people worry about, well, will I get the effects of the amnion in that open port as well? The answer is yes. We see a lateral spread. The visual I always do when I'm teaching other interns and other doctors is imagine pouring syrup on a stack of pancakes, right? You're going to see that syrup spread all across the entire tissue or pancake, if you will. So I would say the pro, or in my case, I tend to order, when I'm doing my purchasing, I order several of the 5s and several of the 8s so that I can get the smaller size for that very specific defect that I just want to put in place before I put a bandage lens on top of it. But if it's a large diffuse area that I'm just treating the whole eye, I'm going to use the Aurora so that they can have a viewport and they can go about their day without any kind of reduction, because I do want to keep that bandage lens holding it in place for around 2 to 3 days.
So the Aurora we're going to use if it's a more diffuse type of injury or that we're trying to treat, or if it's a more concentrated part, then we're more likely to use the Eclipse, the one without the aperture.
That's true. And again, that's my clinical preference. I have some doctor colleagues that just use the Aurora on everything. That way that there's no risk of the patient having a reduced vision. We did a study.
You do have doctors that will use the Aurora, the one with the aperture, on everybody, and they
Yes.
use the one without the aperture, the
Right.
eclipse.
I think it comes down to preference. I think some of your doctors, they just like to have a smaller one. They can put it in place and there's no fold formation. It's just, you just put it in place, tap, tap with the forceps, and it's secured in place and it's easier. Right. But then you have some doctors that want to have that full coverage 360 and get a maximum amount. We did a study on the Aurora comes in two sizes. It's a 10 millimeter with a 5 millimeter port, and then you have a 12 millimeter.
12 millimeter, right?
Right. And so the 12 millimeter has the same amount of amnion as a full 10 millimeter eclipse.
So, and what did the study show?
Studies show that the amnion is going to laterally spread. So if you are comfortable with it and you're not worried about like a central ulcer / central defect, the Aurora is perfectly fine to use for all cases.
So the 10 and the 12 were equal pretty much in the study.
Right. So the 10 millimeter Aurora is the equal to the 8 millimeter eclipse in amnion surface tissue, and the 12 millimeter Aurora is equivalent to the 10 millimeter eclipse from a standpoint of surface amnion. Yes.
So, all right, let's move to the cryopreserved or the wet amniotic membrane. This is a little more complicated to put on a patient. It's also more painful. It's not as comfortable. I don't want to use the word painful, but it's not as comfortable.
It's true.
Tell me about the pros and the cons of the wet type. And you did mention before when you would use a wet type if it was a really, really bad neurotrophic case, where that means that the neurology going to the eye is pretty much not there, and the patient can't really feel the eye, and this eye starts to dry out and kind of starts to die off. And that's what we don't want to happen. The front of the eye, the cornea. But if you could talk a little bit about that.
Sure. So you are correct. The wet / frozen amniotic membrane, it's packaged in a way to where when you apply it, it has a ring involved, what we call a polycarb ring, and you have to put it in place. You have to put the ring in place, and the patient you're going to have to educate the patient that there's going to be some discomfort, but it's the risk reward. So you're educating your patient that you are in a very compromised situation, and we are trying to save this eye from severe scar formation, from severe infection, and you're putting all hands on deck with that one. So the pro is that it's your go-to if you've got a pretty nasty situation where you've had your failed attempts with treatment as far as your medications, and you're right before referring them for some type of surgical intervention or second opinion from a cornea specialist. So the ring is going to stay in place. You're looking at, again, several days with that ring in place. And then the patient, as far as putting it on, I'm not going to say it's traumatic, but it's definitely one where you have to educate them as far as the removal / and the insertion of the ring with the amnion. It is going to be a wet amnion that you're applying in place after you've brought it back to room temperature and got it out of the freezer. So the maximum absorption there is optimal for those pretty bad cases. Cost wise is definitely a con. It is more expensive from an investment standpoint, but a pro would be that it's definitely your go-to if you have a pretty bad situation, and you have to kind of keep it a temperature. You have to keep it inspected. So pro wise would be it's your go-to for your pretty bad cases. So if you've got a patient listening and they go to a clinic that's a subspecialty clinic, there's a high likelihood that they have both types in clinic. And also all of these are usually readily shipped within 24 hours because it is human tissue. So it has to be shipped air and certified and signed for the next day.
Now, does this have more growth factors or hyaluronic acid than the dry, or the more cytokines or stem cells than the dry?
Studies show that the numbers as far as when that actual tissue comes out of the freezer and it kind of reaches it, you are going to see a little bit more of the presence of the cytokines and the growth factors, yes. But from a statistic percentage of what you're using it for, they're fairly equal, yes.
And how long do these last? So the doctor gets them, they put it in the refrigerator or the freezer. I assume the freezer, it's going to last about a year. The refrigerator, maybe 3 or 4 months. But correct me on that if I'm wrong.
You are correct. Freezer wise, for that particular one, you're looking at a year. And then, of course, you have to get it out and be ready. So it's not one of these things that it's going to be a planned application case, right? So that's a con where if you come into my office and you have an emergent situation, we're going to have to lower it, get the temperature back, get it out of the freezer and go and get it ready for you to be applied. Whereas with a dehydrated one, I walk back to my storage cabinet, I get the reverse round tweezers, I can apply it immediately and put a bandage lens in place. So there is a prep
Thank you
time.
Anthony,
And
for a second. This is Dr. Kerry Gell for Open Your Eyes Radio. We're up against the break. We'll be right back. We're back with Dr. Mike Johnson, expert on amniotic membranes. He's a consultant lecturer with ophthalmologics, biological tissue, Inc. And we're talking about wet amniotic membranes, but to take out those membranes, you have to use anesthetic because it could be uncomfortable. Is that correct?
well, so with the dehydrated membranes, the whole point is that it wants to absorb into the cornea. So the only thing you're going to be removing at day 3 or day 4 would be the bandage contact lens, where normally we would use a topical anesthetic just for the ease of mind. And we're going to already be staining and evaluating the patient. So if they were to come back and us remove the bandage lens, we could do that without any anesthesia from a dehydrated membrane standpoint. But yes, as far as a wet membrane that has the polycarb ring in place, you have to use an anesthetic. That way you can get the ring out and get it in a safe manner to be able to evaluate the patient.
So with the dry membranes, going back to dry, we were talking about wet, but let's go back to dry. You have to put a contact lens on it. Explain why it needs to have a contact lens and what's
Sure.
the best method to do it for the doctors listening. Do you put it in the contact lens and then apply it, or is it better to put it on the eye and then put the contact lens over it? What are the pros and cons to both?
So I'm actually going to say that we highly recommend to not put the membrane in the contact lens and then apply it. We have several cases, and that's one of my roles with the company is we'll have doctors call with some troubleshooting issues. Here of late, we've had several call and say that the patients experience a little bit of an irritation where they feel a presence of on the edge. And what had happened is they had applied the amnion into the bandage contact lens, and the amnion was starting to secure to the bandage contact lens, and then they apply on the eye, and different parts of the amnion would be absorbing into the eye. Every time you blink, a contact lens is going to rotate. So you're literally causing it to rotate and almost like you're opening a jar or whatnot. You don't want any kind of grinding or movement at all to an already sensitive and compromised cornea. I would say that our preferred optimal way that we would apply would be directly onto the cornea. And you actually want to have a few seconds. I would say 10, 15 seconds where you use the forceps. We like the reverse geometry forceps where you have to squeeze to open the forceps and then back it away. And they have a round, almost like a loop on the end to where you just literally just tap that in place. The membrane itself is going to have a little bit of an opaque gray appearance to it, white opaque appearance. Once it absorbs into the cornea, you're going to see it turn more translucent and take on the properties of the eye. You as a clinician want to see that. You want to see that absorption for just 10, 15, 20 seconds, then grab the bandage contact lens and put it in place. That way you know that the amnion is already securing to the cornea, and then if you put a bandage lens in place, it won't necessarily shift it or move it. That's very much the case when you're dealing with the aurora, because you want to secure it and keep it in place all the way around, allow it to kind of get in that pupillary zone, especially in their photopic condition, which would be what their pupil's doing during the daytime. I will say that in the nursing home setting, we don't really recommend the bandage contact lens because you're going to have to rely on the administrative / nursing staff of the nursing homes to take care of this patient post-operatively, if you will. So what I normally do is when we're teaching and training these other groups that do nursing home eye care is we do a bandage situation where most of the time your membrane cases are going to be a follow-up. Do them right off the bat when you go into your nursing home setting. That way you can apply the membrane, the amnion, and then we use an eye patch and a second patch where it's folded that we call that a pressure patch. And then we have tape and gauze. And Ophthalmologics was really good. That was a recommendation that myself and a few others had is can we have a kit? Well, we don't want to walk around with all these supplies, but if we order a membrane for nursing home care, they will ship you a bag that has a drape, has tape, gauze, iPads, and a little packet of preservative-free tears. And so that way, if you can keep that in place, keep that eye closed, keep it pressure patched for that 5 to 6 hours optimally, by the time you finish with your clinic on your way out, you yourself can go check on that individual, take the patch off, and then the majority of what you've wanted to accomplish is already in place. So those are the two modalities that we recommend: is the contact lens bandage after it's applied, and then the nursing home eye patch, pressure patch situation.
So, and what drops would you recommend that the patient use? So they have the membrane on. They may
Right.
have a contact lens on top of it, or they may have had a patch. The patch comes off. Now the patient has to have some drops, antibiotic steroids. I know for myself, I'm always using antibiotic steroids. I'm using Tobradex typically to prevent an immune response. Even though we talked about how it's unusual to get an immune response, I've seen some bad immune response, especially with the first patient I did a membrane on, had terrible infiltrates. So now I always use Tobradex, which is a combination antibiotic steroid. I've never had a infiltrate since then. But you're the expert. What do you think?
Right. So what we want to do is, in an eye care setting, you're already going to have them on some type of topical. Usually, it's a steroid of some nature. I prefer Isuvus as a failed treatment from 2 to 3 weeks ahead of time, and then you're going to see, Mr. Smith come in 2 weeks, and it's part of your documentation. So you follow the dry eye workshop, and you're at stage 3. I tend to already have them on that drop, and so afterward they'll continue their treatment drops the next day. While the amnion's on, especially for that first 4 to 6 hours, we would only recommend like a preservative-free teardrop if there's any kind of discomfort with that bandage, contact lens, whatnot. But as far as your antibiotic / combo drops, you're right. Tobradex in my neck of the woods is a little bit expensive. So you do have a generic version that's called Maxitrol, or what we call Neopolydex. The only thing I would recommend is just making sure the patient does not have any sulfa allergies to that. It's usually a pretty cheap drop that you can prescribe them. Another important thing is that your patients will already potentially be on other eye drops, right? There are other problems like glaucoma, where this patient might be taking glaucoma drops at bedtime. What we always say is, you're already on your drops. Your eye pressure is going to be fine for one day. We need you to give us as pristine of a surface as possible to maximize that. So if they're already on glaucoma medications, let's not do those the rest of the day today. Just use the preservative-free tears. Pick up your glaucoma drops the next day and just pick up where you left off. That way we allow that amnion to not get kind of flooded with any kind of preservatives from the latanoprost or the timolols or anything of that nature.
Some of the original membranes, you had to know whether they were inside, which side you had to apply. There was the upside, there was the correct side and the incorrect side. What's the deal with that now?
So as far as the dehydrated membranes, the ophthalmologic membrane is what we call omnidirectional. You literally can apply it either side. And that comes into play really importantly from a clinical perspective, because when you go to apply a membrane, the heat from the patient's body temperature is going to cause that membrane to kind of curl upward a little bit. I always give the visual of like a stingray, where you'll see a stingray effect. And some doctors get a little panicky and they're like, well, what do? I don't want to have a fold. The beauty of it is you can just literally flip over your forceps and just use the other side. And that curled up side will just literally fold and just curl right back down onto the cornea, and you get a perfect application. The ones that have the polycarb ring, that are the frozen and the wet, usually they have a front side and a back side, so you know which way to apply properly. There is a proper way for that. But most all of your dehydrated membranes are bidirectional, to where you can apply them on either side.
Do you think there'll ever be a time where they use this as a delivery mechanism, where they may put antibiotics in it or some kind of for allergies, some kind of medication for allergies, or even who knows what, even glaucoma? Do you see that in the future?
I do. They're already working on that in Europe, actually. What they're finding is that, in the world of genomic 3D printers and bio 3D printers. Matter of fact, here in Alabama, at the Alabama Eye Bank, that's a nonprofit group. They have one of two tissue printers where they actually can reproduce the same tissue product to get it from donation standpoint. They're using that more in research for corneal transplants, endothelial transplants. And so in Europe, what they're doing is they're infusing the synthetic amnion that they're trying to produce, and they're doing studies where they're infusing it with olopatadine and dexamethasone. So it's in the pipeline. But if you know anything about the United States of America, we have this wonderful thing called the FDA. So it's going to be many years and many millions of dollars. But yes, to answer your question, there are those, and there's already a company that we worked with. Ophthalmologics did a study with. They have a contact lens that has been infused with one lens that's infused with amoxifloxacin, which is a fourth generation fluoroquinolone antibiotic.
Well, hold that thought, because
Okay.
we'll have you for next week. We're going to have you come back and we're going to
Sure.
talk more about this. But if people want to find out more about you, how could they do that, Mike?
Sure. So they can go to ophthalmologics.com and take a look at that. And then, of course, myself, I'm on LinkedIn. And then I'm at my practice is Dr. Michael Johnson and Associates.com as well.
I want to thank Dr. Mike Johnson for joining me, but he's going to join me again next week. This is Dr. Kerry Gell for Open Your Eyes Radio on wellness1280.com.
Your eyes and your vision are under attack, damaging blue light from the sun. Your phone, your computer, your tablet, even light bulbs and car headlights is constantly bombarding you. The good news is our eyes actually already have a line of defense to counter the effects of blue light. This defense is made up of 3 pigments called carotenoids. MacuHealth with Micromicelle, the only supplement with the exclusive patent on all 3 macular carotenoids and Micromicelle technology.
Fitting multifocal contact lenses presents a big opportunity to meet patient needs while growing your practice. Alcon is your partner not only with our innovative portfolio, but through e-learning. Learn to enhance your multifocal strategy today with the Alcon Experience Academy.